We are live.
Yeah, good evening, everyone. Thank you so much for joining this meeting, organized by the Comprehensive Breast Collaborative Society. It's the symposium organized by them and supported by AstraZeneca. This meeting is being led by Dr. Shona Nag, who is the Director of Oncology at Sadri Group of Hospitals. And with further ado, I hand it over to Dr. Shona to, begin the meeting. Thank you.
So, hello everyone, good evening, and really happy to have you here. You must be wondering what this Comprehensive Breast Collaborative Society is. So, I think a bunch of us got a little fed up with the male breast surgeons, and they used to, monopolize every single meeting. So, a bunch of 7 of us, women, surgical breast surgeons, medical oncologists, and radiation oncs got together with a purpose to share data, with a purpose to collect data. We've had a few meetings where we've shared data on our BRCA patients, on the axilla, etc. There is an ongoing study for young women with breast cancer as well. So they've had many meetings from the surgical point of view. They've had meetings on benign breast diseases, which I was forced to attend. But now today is, I think, a chance for the medical oncologists to shine. And we've got a great lineup for you. Today's format is a little lengthy, but I'm sure will be very full of learning. So we've got an overview by none other than Dr. Sevanthi Limaye. This will be followed by case discussions, so where all we can use the newer anti-HER2 molecules in our current setup, both in the early and metastatic setting. So students will present cases and we can ask questions. And thereafter, we'll have a panel with experts. So right from the time of 1998, where trastuzumab was first approved by the FDA for metastatic HER2-positive breast cancer, right up to 2026, we've come a long way. And in these last 30-odd years, we've got a whole lot of new molecules, the latest being TDXD. And there is so much data with this drug that we are certainly floundering with where to use it correctly and properly. And I'm sure Dr. Sevanthi will shed some light on that. So may I please request Dr. Nagesh Sisat, who's the chairman of this session, to introduce Dr. Sevanthi and take this meeting forward. Thank you.
Thank you, madam. Am I audible?
Yes, sir. You're absolutely audible. Please go ahead.
Good evening, everyone. First of all, I would like to thank Shona Nag madam for having me here. It is always a pleasure listening to her and learning from madam. It's my honor to welcome and introduce Dr. Sevanthi Limaye madam. Madam is the Director of Medical and Precision Oncology at Sir H.M. Reliance Foundation Hospital and Research Center. She completed her residency in internal medicine from New York University and did her fellowship in hematology and medical oncology at Albert Einstein University, New York. She has been involved in research with leaders at MSKCC, Dana-Farber Cancer Institute, Columbia University Medical Center, and National Cancer Institute, USA. She has served on the Tata Memorial Hospital Ethics Board. She has led several national and international trials and is the recipient of many awards, including but not restricted to the prestigious Medical Oncology Research Excellence Award, ASCO 2008. I'm sure it will be a great learning experience for the students as well as for all of us. With this, over to you, madam.
Thank you so much. Thank you so much for the kind introduction. And thank you, Shona Nag ma'am, and the Breast Collaborative Society group for this opportunity. And it's a proud privilege to be presenting in this meeting today. Is it possible for me to share my slides?
Team, if you can just help. Yeah, perfect.
So we are going to be talking about HER2-positive breast cancer and the evolution of management. There's so much to present. I'm going to rush through some of the slides and touch upon some of the concepts briefly. So essentially, when we talk about HER2-positive breast cancer, it is actually the second most common type of breast cancer. And we have right here, if you look at the bottom classification, triple positive disease listed as luminal B, and then you have HER2 positive, hormone negative, which is called HER2 enriched. And then you have the hormone positive, which is luminal A, and the triple negative, which is basal-like, that we call when classifying. Here we have HER2 amplification, HER2 overexpression, which we all know is an aggressive disease. It's a negative prognostic factor. It has poorer survival and increased risk of metastasis. And that story brings us to what is one of the most powerful drugs today, which is TDXD, specifically engineered against HER2. And for the HER2-directed therapy, this is an antibody-drug conjugate, which has a monoclonal antibody base and a topoisomerase 1 inhibitor payload. And this is with a tumor-selective cleavable linker, which is attached to the payload and the antibody. And the linker payload is stable in plasma and linker selectively cleaved by enzymes that are upregulated in the tumor cells. And the difference between TDXD and TDM1, where topoisomerase 1 inhibitor as a payload versus microtubule inhibitor for TDM1, we know that for a very long time. We have the 8:1 drug to antibody ratio versus 3.5:1. So it's a stronger drug when it comes to the payload carriage, payload anchorage, and tumor selective cleavable linker versus a stable linker for TDM1. And here's a diagrammatic representation with a bystander effect also seen with TDXD versus TDM1. So you see a bystander effect to the neighboring cell, which you don't see it in TDM1. And we also know that breast cancer patients that present to us, even with HER2 positive disease, in substantial percentages are diagnosed in early stages or loco-regional advanced stages. And we have application of these molecules beginning from advanced stages into the locally advanced breast cancer as well. We have here the guidelines recommending chemotherapy plus trastuzumab, pertuzumab in application for treatment adjuvant or neoadjuvant situations as well for locally high-risk breast cancer, wherein T2 and above and node positive and above patients should be receiving a combination of dual HER2 targeting along with chemotherapy. And this mostly in neoadjuvant stage, neoadjuvant style, and then followed by surgery for these patients that present with high-risk HER2 positive disease. We have the Neosphere trial, which was a phase 2 study where this regimen was utilized in the neoadjuvant period. We had the THP, the TH, HP, and the TP, and the surgery followed by adjuvant treatment. And you saw that the THP was a winner in PAT-CR, laying the story for many more trials that would come later with a very high PAT-CR rate with the neoadjuvant treatment of dual HER2 inhibition. We also do understand that the residual disease with the comparator arm was significantly higher than what we saw with the application of dual HER2 inhibition. In the Destiny Breast 11 study, which is the talk of the town now, we have TDXD 4 cycles followed by THP 4 cycles versus dose-dense AC followed by THP in the second arm, and the third arm was TDXD. All of that was 8 cycles. And this was surgery followed by PAT-CR or no PAT-CR. And stratification was also by HR positivity or not. And primary endpoints were PAT-CR. Secondary endpoints, PAT-CR by blinded central review, event-free survival, safety, and others, including quality of life and overall survival. And here, if you see, the primary endpoint was met both in intent to treat population, and the blue bar represents the TXD THP combination, which was significantly better with a delta of 11.2 in comparison to the comparator arm, which was dose-dense AC followed by THP. And this advantage was seen in both hormone positive as well as hormone negative. Of course, the hormone negative, HR negative patients have always had higher responses, higher benefit from HER2-directed therapy, and that's what we see here. Again, the delta goes up to 16.1% in the hormone negative population. When we look at the residual invasive breast cancer outcomes in the intent to treat population, again, there was a significant delta of 12.2%. In the hormone positive, 13.3%. In hormone negative, it was 9.2%. And the safety summary is laid out here, where my eyes go directly to ILD and pneumonitis, and you see the difference between the experimental arm, including TDXD with THP versus AC, followed by THP. There isn't a very significant difference. This is 4.4 of drug-related ILD versus pneumonitis. And in the comparator arm, it's 5.1%. And the LV dysfunction is actually higher in the dose-dense AC followed by THP. So you have an aggressive regimen with TDXD where chemotherapy payload is being utilized alongside a MAB and a trastuzumab linker, and with THP versus anthracycline followed by anthracycline-based treatment followed by THP, where now there's a significant difference in the LV dysfunction being 6.1 in the AC followed by THP arm. But when you look at the grade 3s and the grade 5s, the numbers are still low. Nevertheless, if you include all grades, the rates are higher in the anthracycline arm. So when we look at the guidelines, post-neoadjuvant adjuvant therapies, what is the data now? And when you look at residual disease, we have data from application of TDM1 with or without endocrine therapy. This is the Catherine data. And then you have the neratinib with or without endocrine therapy for high-risk HR-positive early breast cancers, with endocrine therapy for high-risk HR-positive early breast cancer. So Catherine showed us that if you had residual disease after the neoadjuvant treatment, when the surgery happened for these patients, with 1:1 randomization with TDM1 and trastuzumab, you had benefit from TDM1 versus trastuzumab. That was the Catherine data. And in Catherine, post-neoadjuvant TDM1, we saw post-neoadjuvant therapy, TDM1 significantly reduced the risk of death by 34% versus trastuzumab. And this was a secondary endpoint. Well, when you look at opportunities to improve post-neoadjuvant treatments in HER2-positive breast cancer, we look at the improvement with PAT-CR. So if PAT-CR, the 3-year IDFS was 97%. But those that had residual disease, the 3-year IDFS was in the range of 77 to 88%, clearly outlining that these patients were actually difficult, that these patients had they had a lacuna and they had real issues with disease relapsing. In today's times, when we have excellent drugs to harness, to capture this disease, and lead to 100% cure, there is an opportunity. We have to understand our lacuna, and this is significant lacuna that really can be transformative if we were to apply the right strategy. So there comes Destiny Breast 05 study, where you have residual disease, invasive disease in the breast and or axilla lymph nodes after neoadjuvant chemotherapy with HER2-directed treatment. And high-risk disease was defined as presentation prior to neoadjuvant treatment with inoperable early breast cancer or operable early breast cancer with axillary node positive disease, where you had YPN23 disease after neoadjuvant therapy. And this also had to be centrally confirmed and good performance status. And you have 1:1 randomization with a stratification factor of extent of disease at presentation, inoperable versus operable, HER2-directed therapy, where you saw either single HER2-directed therapy or dual HER2-directed therapy, hormone receptor status, hormone positive, negative, and post-neoadjuvant therapy, pathological nodal status were positive versus negative. And what did these patients? What were these patients given? 1:1 randomization, 1,600 patients, TDXD versus TDM1, and IDFS was the primary endpoint, DFS secondary endpoint, overall survival, and others as the other secondary endpoints. And of course, you had one of the major monitoring happening here for interstitial lung disease, which is mostly all our concerns, because this is going to happen in the setting of radiation. And radiation here could be initiated concurrently with the study therapy or completed prior to initiation of the study therapy, which is sequential per the investigator. And I would certainly be nervous in giving concurrent radiation, and that's why I like the fact that both options were given. And here you see 53% reduction in the risk of invasive disease recurrence or death for TDXD compared to TDM1. And this is the exact same problem I had yesterday in clinic, and I'll come to you in a minute with what decision I took for this patient. And if you see here in secondary endpoints as well, in disease-free survival, so this was IDFS, invasive disease-free survival, and DFS right here, where there is a delta of 8.8%. And then you have overall safety summary with, when you look at drug-related ILD, for TDXD, the numbers are higher than with TDM1. And this is something that we will be observing the space for. You have to pay attention to, in the TDXD arm, the causes of death, number 3 were 2 with ILD pneumonitis and respiratory tract infection. And in the TDM1 arm, there were 5 deaths, which were unrelated to pneumonitis. Very important to keep that in mind. Adverse events of special interest with ILD and pneumonitis and LV dysfunction. And so if you see here, drug-related ILD, when you get to grade 3, actually, the numbers are not hugely different. Nevertheless, this is a space that we are going to watch for very, very closely, especially now that DB11 is coming in. We have to, again, pay attention to what the patient utilized earlier, whether TDXD was utilized earlier. And that's a data gap that if we, again, have to think of residual disease and which drug to give, we have to be very careful, because we may end up looking at DB5 and utilization of TDXD for adjuvant patients. And this study does not have that information with what happens to patients who were exposed to TDXD earlier as a part of the DB11 regimen. And if you could give them TDXD again. But here, the LV dysfunction rates were also not impressive, not very different. And from an LV dysfunction angle, this was considered to be safe. I think so how much time do I have? Just wanted to understand.
You can go on.
Yes,
yeah.
So now we come to metastatic breast cancer. And here we also know that metastatic HER2 positive breast cancers are an aggressive subtype. My journey into precision actually started from the metastatic HER2 positive breast cancer patients that as an intern, I did a data collection of 2,000 patients with metastatic breast cancer patients that were HER2 positive. This is way back in 2003. And this is a study that I did under mentors at Sloan Kettering Cancer Center. And I remember patient after patient seeing magical results with HER2-directed therapy. And these HER2, the trastuzumab had actually just come in. And there was so much excitement with what it could do to HER2-positive patients. So even though we are talking metastatic breast cancer, we know that HER2-directed therapy actually changes the horizon for these patients. And we see that with our patients time and again, where if you look at these bars, look at the localized disease, you have such excellent survival. The bars on the right are still half the size of the localized, of the regional bars. And that's what the message is. With drugs as brilliant as the one we discussed just now, we still are falling short of getting to the best survival. Having said that, TDXD fills the lacuna that we see here with bars that are so low, where there is a huge gap to fill. So patients with HER2 positive metastatic breast cancer should be receiving the best therapy, the most effective treatment in the first line setting. And as we say, best drug first should be offered to these patients to fill the gap because of this very reality that only a certain percentage of these patients will receive second line treatment and third line treatment and may not be able to be around to receive the best drug because they never got it in the first two lines of their therapy. So if you look at the NCCN guidelines in the frontline setting, of course, there is the original regimens with dual HER2 inhibition with pertuzumab and trastuzumab and docetaxel, with paclitaxel, pertuzumab, and trastuzumab. And as we have seen more recently, carboplatin has actually been taken out of this combination, where it's actually found to be the docetaxel pertuzumab trastuzumab arm is found to be equivalent to when you add the carboplatin to this regimen, and to preserve quality of life, this 3-drug regimen is found to be good enough. Paclitaxel plus dual HER2 inhibition is considered to be good enough, but still you can do better. And that's what the next few slides is about, where we are going to discuss Enhertu plus pertuzumab and what it brings to the table. And of course, in the second line setting, you have the HER2 climb and the trastuzumab deruxtecan, Enhertu and the TDM1, and all others making into the third and the fourth line of therapies. So beginning with the Cleopatra data of docetaxel plus dual HER2 inhibition, and the curves nicely separating, proving the point. Moving on to the Patina trial in hormone positive, HER2 positive, triple positive metastatic breast cancer, where we now see the arrival of CDK4/6 inhibition, adding to the benefit from the HER2-directed therapy in this difficult-to-treat cohort of patients where we would give HER2-directed therapy, we would give an endocrine therapy, but even up from that, if you have added CDK4/6 inhibitor, you see significant advantage, significant survival advantage for these patients by addition of cell cycle inhibitor for this cohort, where we saw patients behaving differently from a purely HER2-driven pathway to those that were a mixed cohort with HER2 and hormone guiding the biology of this disease. Addition of a cell cycle inhibitor adds to the progression-free survival, and you see the overall survival difference as well. Of course, when you add another modality of treatment, it adds to the side effect profile as well. But if you really look at where we are today, we have the Cleopatra data, we have the Patina data for triple positive disease. Still, we have a very heterogeneous mix of patient population with the aggressive disease demonstrating visceral and bony metastasis with PIK3CA positive presence, and with hormone positive disease adding another angle to HER2 positive breast cancer. And that's where the DB09 study aims to address this lacuna, this gap of multiple unmet needs, where you need something more than just the trastuzumab, pertuzumab maintenance that remains after a hard-hitting initial chemotherapy plus dual targeted treatment that we saw in Cleopatra. Post that, when you left the patient on maintenance, you saw all these relapses happen because the patients can't remain on these chemotherapies forever. You stop the chemotherapy, you keep the patient on targeted treatment, the dual targeting, and that's when you saw the relapses happen, the brain metastasis, the visceral metastasis, the quality of life transforming metastasis for these patients. And that's where the need for the antibody drug conjugate we all have realized through TDM1, and still the unmet need of an improved survival being brought to us through TDXD. And so you see the DB09 study, which may provide data to support the use of TDXD in frontline, improve outcomes in HER2-positive brain metastasis patients, liver metastasis patients, and also patients which have heterogeneous disease with PIK3CA mutations and hormone-positive disease. And I was in a particular session where we were discussing and how actually PIK3CA adds another angle to the biology of a HER2-positive patient. And here you see the addition of pertuzumab to TDXD will actually lead to, it shows how it could lead to the inhibition of cell proliferation and survival through the PIK3CA mTOR pathway. It also provides the apoptotic cell death, and it also leads to the bystander, facilitating of the bystander effect that wasn't seen with pertuzumab, trastuzumab alone. And here it happens through prevention of heterodimerization and prevention of homodimerization that is seen with TDXD. That brings to the core of discussion of Destiny Breast 09, which is a phase 3 open label randomized trial where you saw utilization of TDXD plus pertuzumab in the experimental arm, THP was the other arm, and TDXD plus placebo was the third arm, 1:1:1 randomization frontline setting of metastatic HER2-positive breast cancer. And you see the curves very nicely separating between TDXD plus pertuzumab versus THP. And when the curves are separating so nicely, it actually is self-explanatory. You see a hazard ratio of 0.56 and a significant separation of curves, not just in the intent to treat population, but also in the hormone receptor status. So hormone positive versus hormone negative patients, in PIK3CA positive versus PIK3CA negative patients. All of these patients benefiting from the combination of TDXD plus pertuzumab. And in these patients where you have the secondary endpoints as well as safety, which favored the secondary endpoints with overall response rate and duration of response favored the combination arm, regardless of the prior treatment status, including the hormone-positive PIK3CA, clinically meaningful PFS2 demonstrated with TDXD plus pertuzumab versus THP alone. No new safety signals were identified. This is also extremely important. The overall survival is only with 16% maturity. The curves are already separating, but we have to wait and see how this actually pans out in terms of the different subgroups that it was addressing. Treatment-related adverse events were also quite comparable, and we have to be cognizant of the fact that we are adding a second HER2 inhibition when we look at the pertuzumab addition to TDXD. Having said that, when you look at the THP arm as well, we know that there are dual HER2 inhibitions. So whether it is TDXD plus pertuzumab or THP, we have dual HER2 inhibition happening in both. It is just the payload that separates the two arms of the study. So we have to be cognizant of the watched toxicity, both ILD and left ventricular dysfunction. And when you look at the experimental arm and the grade 3 toxicity, I felt quite reassured in knowing that actually there aren't significant differences both in the experimental arm of TDXD plus pertuzumab and in the ILD pneumonitis versus left ventricular dysfunction. You have no significant safety signals coming through. When we look at the Cleopatra, Patina, and the Destiny Breast 09 data and look at it side by side, there are certain differences, of course. We have the studies approaching different categories, different criteria, especially the Patina trial actually was looking at the hormone-positive disease in particular. The Cleopatra and the Destiny Breast 09, the biomarker of eligibility was actually just HER2 positivity. So that separates these two trials from the Patina trial. Prior therapies, we had chemotherapy plus trastuzumab allowed. Here, the requirement was prior induction therapy with 4 cycles to 8 cycles of chemotherapy plus HER2-directed therapy. Patients with prior CDK4/6 inhibitor were actually excluded. This is also not a standard of care, so it would only have been on clinical trials. And in the Destiny Breast 09, because this cohort also had subgroups of hormone-positive disease, there are certain nuances in the inclusion and exclusion criteria that had to be paid attention to. CNS metastasis was excluded in Cleopatra, so that is a very important exclusion. And in Patina, asymptomatic CNS metastasis was included, and even in Destiny Breast 09, clinically inactive or asymptomatic patients, but brain metastasis was included. So these are very important differences. which need to be paid attention to. That brings me to the last leg of the presentation, where we are talking about Destiny Breast 03, which was an open-label, multi-center phase 3 trial, which saw utilization of TDXD versus TDM1 in the unresectable or metastatic HER2-positive patient population that had been previously treated with trastuzumab and taxane. Patients with clinically inactive asymptomatic brain metastasis were also allowed. They would have had treatment and stabilized. Stratification factors were hormone receptor status, patients treated previously with pertuzumab, visceral metastasis, brain metastasis were measured at baseline and monitored throughout the study. And this, again, with a primary endpoint of PFS, secondary endpoint was OS, and other secondary endpoints, duration of response, overall response, etc. Safety was also included. And the exploratory subgroup analysis was also very different exploratory analysis were also included, which we will discuss later. So if you look at the investigator-assessed PFS, you could fit in 2 rulers. So hands down, there was significant benefit, and we have all followed this data for a very long time. We have overall survival advantage, which is significantly different between TDXD and TDM1. And when you look at the safety summary, mainly, again, homing in on ILD, this is a space to be carefully followed. Grade 3 toxicities were not hugely different, but adjudicated drug-related ILDs were significantly different between TDXD and TDM1, but grade 3 were not significantly different. And we need to know that as we approach our patients with the drug choice. I think we've all taken over very, very nicely to TDXD application in this setting. But the challenge remains in a resource-limited nation. The challenge remains with the costing. Nevertheless, science has to prevail, and it's needless to say that this is a wonder drug. It is globally accepted as a wonder drug, and it has really brought a huge change to how we practice HER2-directed therapy today in HER2-positive breast cancer. Metastatic breast cancer is where the story began, and the story slowly but solidly moving into early breast cancer with all the data that we discussed just now, with starting from the late stage HER2-positive disease, moving into the early stage disease that we started out with, the Destiny Breast 11, the Destiny Breast 5, the Destiny Breast 9, the Destiny Breast 3, all of that data coming in to help move the field forward and change, bring in a paradigm shift, bring in a paradigm shift in the outcomes of breast cancer, HER2-positive breast cancer, all the sub-cohorts that are now there, that were our challenges in the yesteryears, in the past, where we will see a transformative difference as we are able to bring this molecule up and up, not just in the locally advanced, but also early breast cancer setting. The space to watch out for is the application of CDK4/6 inhibition, the newer hormonal therapies like giredestrant, arrival of new age PIK3CA inhibitors, and also of utilization of immunotherapies in unresolved setting. We really are to watch that space. And of course, the combinations like tucatinib with TDXD, and the combinations like atezolizumab with or other immunotherapy trials that are being conducted with TDXD. That's the space to watch out for. And that leaves us with a lot of hope that we will still continue to move the needle for HER2 positive breast cancer with whatever lacuna remains. More so recognized challenges with hormone positive and PIK3CA positive disease that many of us still find quite challenged, even in the setting of HER2-directed therapy with ADCs. So thank you so much again for the wonderful opportunity. I bring it back to the AstraZeneca team and to Dr. Shona Nag ma'am, and looking forward to very interesting discussions. And thank you, Chairperson, for chairing this session as well. Thank you.
Thank you so much, Dr. Sevanti. That was a fantastic session, really. It was an overview, a comprehensive overview of HER2 positive breast cancer as well as the TDXT trials. I believe we can move on to our next session, which is case discussions by a few students, followed by a Q&A session. How we'll be doing this session is we'll have two cases presented, followed by a Q&A, again, another two cases and a Q&A. So I hand it over to Dr. Shona to carry over to the next session.
That's great, Sevanti. That was wonderful and pretty clear about both the early and the metastatic setting. But yes, a lot of confusion also on how to sequence and whether PIK3 is going to really play a big role in choosing between TDXT and the Traspert combination. So yeah, there are exciting days ahead for us. And I think what was very, very interesting in the early trials, for the first time, we included T4 disease. And we included really, really tough disease that we struggle with and are not normally included in neoadjuvant trials. So I think it's relevant to our setting because we do come across these inflammatory breast cancers and we're pretty helpless at that time with what to do. So I think that's a situation where I would really like to jump in with neoadjuvant TDXT. So without further ado, Dr. Bhakti, if you're ready, you can complete your two cases and then we can have a bit of a discussion. Over to you.
Can you please, the support team, can you please put on my slides?
So Bhakti, for all those who are not acquainted with her, is our third year DNB student. And she's been part of the treatment of the two cases that we'll be discussing.
Hello, can the support team please put on my slides?
Team, can you share the slides, please?
The next slide.
Yeah, oh, fine.
The next slide, please. Yeah. So, good evening, everyone. So, this is our first case. So, this is a 35-year-old female, premenopausal, no comorbidities. She was evaluated for a right breast lump which she noticed since 3 to 4 months in September 2024. So clinically, she had a bright breast lump of around 3.5 to 3 centimeters with skin thickening and with right axillary lymph nodes. So with the biopsy, it was a IDC grade 3, ERPR negative and HER2 3 plus with a Ki67 of 30 to 32%. The whole body PET CT, though it showed a right breast lesion, the primary, with some satellite lesions, with right axillary nodes, right supraclavicular lymph nodes, right pretracheal lymph nodes, and 2 liver lesions in segment 6 and 7. Next slide, please. So for the treatment part, since she had an oligometastatic kind of picture, we decided for a curative intent management. So we went ahead with paclitaxel and Pesco. 6 cycles, and because of some logistic issues, we continued with Fesgo because she could not do the surgery after the 6 cycles of Pacli and Fesgo. But in the reassessment PET scan after the 6 cycles of Fesgo and Pacli, there was some residual lesion in the right breast and the right axillary lymph nodes, but no liver lesion was seen. The mediastinal lymph nodes had also completely responded. And so to confirm it, we also did a CT abdomen and an MRI abdomen. And in that also no focal liver lesion was seen. Next slide, please. So this is her PET scan pictures throughout the treatment. So we can see here that initially the 2 liver lesions and the mediastinal lymph node there. In the further scans during the treatment, all those lesions have responded completely. And so then she was planned with for surgery with curative intent, which happened in June of 2025. So she went ahead with a right MRM plus axillary lymph node dissection, and her HPE, it showed a YPT1AN0 RCB1. And then she underwent adjuvant locoregional radiation, and currently she is on adjuvant TDM1. Next slide, please. Yes. So the points to discuss in this case was that whether we could have used TDXD in the adjuvant setting if she had some node positive disease, or a TDXD in the neoadjuvant setting in a locally advanced disease or a oligometastatic disease as she had.
So I think this is a case all of us come across pretty often. An oligometastatic HER2 positive cancer with a locally advanced primary. So Sevanti, let me take that to you with the kind of data you presented just now. Would this lady have qualified for these newer approaches, and would you be comfortable using TDXT either in the neoadjuvant setting for 4 cycles, or would you have preferred it in the residual disease setting?
So for this patient, I think, ma'am, I would have preferred it more in the residual disease setting.
Right. Okay.
While I was presenting, I was reminded of the 2 recent patients where I have thought just 2 days back, I had a patient who had 6 centimeter breast lesion, and lymph nodes were tracking the largest. On examination, it was at least a 6 centimeter lymph node conglomerate in the axilla, and
My
lymph nodes
goodness.
were tracking through beneath her pectoral muscles, and I could feel them from outside as well. And this is a 44-year-old, and ERPR negative, HER2 positive. So that patient, I absolutely thought of TDXD. I also had another patient earlier where the entire breast was involved. So it was an inoperable breast with internal mammary, with subpectoral, with axillary lymph nodes, but still not metastatic. So,
okay.
That's the kind of bulk where at this juncture, I absolutely thought TDXD. Having said that, I think the field will move forward where we will look at neoadjuvant versus adjuvant application. For now, I would want to give adjuvant for residual disease. I would like to utilize TDXD in the adjuvant setting for this patient. It seemed to me that the patient had low axillary burden, if any.
Yeah.
So,
yeah.
I'm just describing the 2 patients that I found
Yeah.
very high risk in my practice, and would be more befitting for the Destiny Breast 11.
Absolutely. So any other thoughts from our experts, Chakur, Dr. Nagesh?
I think this patient had in urgent setting, we are using in only 4 doses. In adjuvant setting, there are more number of doses. This patient had N2, N3 supraclavicular node was also there. So,
Yeah,
no,
so I think this is a tough one. And had she had residual nodes in the nodes, I would have been very eager to push for something more than just TDM1. But we kind of got rid of the nodal burden very nicely, and her liver lesions disappeared. And of course, and this data wasn't out then. So that's another question. Bhakti, would you like to proceed
any
with your...
data for low dose PhD, madam? Any?
So we'll be coming to your controversial question in the third case, where I have taken the liberty of using low dose, and we can discuss that, but not in a curative setting. I don't think I'd like to fool around with the low dose TDXT in a curative setting. So, and there's no data. I think we in India are using a bit of it. We need to collect our data and pull it together. So let's, Bhakti, go ahead with the second case.
Yes, ma'am. In the next slide, please. Yeah. So this is our second case. So she was a 67-year-old female, no comorbidities, diagnosed in August 2023 with a de novo metastatic right CA breast with lung lesions and mediastinal lymph nodes. So biopsy from the right breast lesion showed a IDC grade 3 ERPR negative, HER2 new 3 plus. Then she was started on a combination of paclitaxel and trastuzumab, and then trastuzumab maintenance till March 2024. Dual anti-HER2 was not used because of the logistic and financial issues. Then PET-CT from March 2024, it showed a progressive disease. Started on capecitabine and lapatinib that she took for around 5 months from April 2024 to September 2024. Again, in October 2024, she had a PD in cervical lymph nodes and some PD in the lung lesions also. Then she was started on trastuzumab plus capecitabine and lapatinib, which she took from October 2024 to January of 2025. Next slide. So this is the imaging. So this August 2023 is the initial imaging, which had a huge disease burden in the breast and also in the lungs and the mediastinal lymph nodes. With trastuzumab and paclitaxel, that had come down, but again then there was a PD in March 2024, and in October 2024 there was some response, but still there was a quite significant burden of disease in the PET-CT. Next slide, please. Then in CT thorax of Jan 2025, she had a PD in the lung lesions. So she was started with TDXD since Jan 2025, and as for now, she has completed 18 cycles and still ongoing with TDXD. Next slide, please.
So this was only possible because we did the phase 4 study at our site at Sahyadri for TDXD in heavily pretreated patients who had progressed on several lines of anti-HER2. Go ahead.
So this was the initial response after the three first doses of TDXD from March 2025. So we can see that there is a significant reduction in the burden of the disease in the lungs. Next slide, please. And these were her subsequent scans from August 2025 after 9 doses of TDXD, and this is her latest PET scan from February 2026.
Wow.
So, but I've had to dose reduce for this patient because I think, Sevanti, you've experienced the same thing, and my experts in the panel also, that they tolerate the first 8-9 doses very well. And then they begin to get quite a bit of fatigue, and they do have interference with the activities of daily living. And that's when I kind of do 1 dose reduction and sometimes up to 2 dose reductions for them. So that's been my experience in these patients that we've treated on the phase 4 and in practice. What about my colleagues? Any similar experience?
So I completely agree, ma'am. We have to go down on the dosage to make it more tolerable for the patient. A lot of patients, start to ask if they could stop treatment. It's not that a common occurrence with Fesgo, but now especially, I mean, I come from the time where we were giving Trastuzumab in intravenous. Then it came Fesgo. So Fesgo is certainly way easier. And once a patient has taken, always keep wanting to go back to it.
Yeah.
But nevertheless, from TDXD, as also we saw from TDM1, patients are always asking when the therapy will finish.
Yeah, I think both these drugs are tough drugs to take. So the minute you get to an ADC, it's not easy. They begin to lose a little weight. So I think and they don't feel hungry and they just say they don't feel themselves. Once you dose reduce, you kind of been able to push them there are some that are nearing 2 years of completion. So there are ways of getting around these toxicities. And of course, every 3 months, we do a high-res CT of the lungs. And at the slightest sign of a cough, we're very vigilant. And we've just had, luckily, in these 15 patients on the study, maybe one with a grade 1 to 2 ILD where we had to stop. So we haven't had such, 11 to 16% ILD that we've seen, but maybe it'll come. So we don't know.
Right.
And I think we can go on to the third case. That's also interesting. Arun, would you like to present?
Yes.
So Arun is our second year student. Go ahead.
Could you please share me?
Very nice.
Hi, good evening, everyone. I'm presenting a case. Next slide. Okay, this 47-year-old female. She's diagnosed with carcinoma left breast in December 2020. Without any metastatic workup in outside hospital, they had done a surgery, left BCS, and it showed IDC grade 2, ER90, PR80, and HER2 was negative. Post surgery baseline PET shown multiple bone mets in vertebrae. So after BSO, we started Letos, Palpo, and zoledronic acid from Jan 2021 to December 2023. In 2023 December, showed oligoprogression 1 bone only, D7 vertebrae, and we have given radiation to that D7 and continued the Letos Palpo combination with zoledronic acid. After a DFS of 3 years, 10 months, we repeated the PET-CT, which showed new lesions in the liver, multiple in both lobes. We took a biopsy in liver. It showed ER90, ER60, and HER2 plus fish negative, and showed an ESR1 missense mutation. And we started with chemo, kept cytarabine for 3 months. It progressed. After that, we started with weekly PECLI. After 9 doses, progressed. Liquid biopsy showed missense mutation ESR1 also. Then we started with exenestine and everolimus from June 2025 to October 2025 and progressed in liver. Next slide. After that, in October 2025, this is progress in liver, showed ascites with bilirubin of 12. We started with NHER2 100 mg 3 weekly in October 2025. We considered low dose in NHER2 in view of affordability issues. Next dose. After starting this NHER2, after 4 doses, we can see there's gradually decreasing bilirubin from 12 to 2.1. Next slide. And we can see in the PET-CT showed there is significant reduction in the disease burden in the liver in Jan 2026. Next slide. Next slide.
Okay, go on.
Then we continued 4 more doses. After 6 months, we completed 8 doses, and we got a PFS of 6 months. After that, she progressed in liver in April 2026. Now we started with fulvestrant and next slide. Currently, she started with fulvestrant abemaciclib. Now we are discussing. We have to discuss low dose Enhertu and Enhertu in visceral crisis.
So I was very keen on exploring a SERD as well. I mean, the best one I came up with was fulvestrant because they can't afford any other SERD. But I know that she is unlikely to respond to this combination as well. I mean, she may have a short PFS. Any other thoughts on this patient? Get a CGP, but then she may not afford anything that it shows up. But should I do the agnostic markers, Sevanti?
So, ma'am, this smells very, very PIK3CA.
But the last liquid biopsy did not show it, so I should do it on the tissue.
Yes, ma'am, I think so.
Okay.
So this could be AKT, P10, PIK3.
Yeah, one of those.
One of those, because this is so much disease burden in the liver. It makes me think that Enhertu got rid of it for a while.
Yeah.
Now it's escaping even Enhertu. That's my thought regarding this.
My problem is getting capivasertib or a drug like that. That would be the right drug if she shows any of those, mutations. But in our country, you are so sometimes bogged down with affordability. We see a lot of these patients, and we know what we have to do ideally. Ideally, I know the way it works, but I'm not able to, implement that.
Yeah.
Any other thoughts, guys? Clinical trial, if you have one, Sevanti, let us know, please.
And ma'am, all the patients that you've shown, they're all, trial patients. And one that you were able to offer Enhertu, and it looked
really, she did so good.
Power of these drugs that we can facilitate to our patients. If you had an inavolisib or a capivasertib today, I think magic happened for this patient.
Yeah, for this patient, correct. Okay, we have a last case, Christian.
Yes, ma'am. I believe Dr. Piyush would be presenting that last case. Dr. Piyush, if you could share your screen and present it.
Good evening, esteemed faculties. I am Dr. Piyush Varia, first year resident in Department of Medical Oncology at Aditya Birla Memorial Hospital. I'll be presenting a case of breast cancer that has been recently discussed in ISMO webinar series as well. So our patient is 75-year-old women with no family history of breast cancer, present into OPD with 5 centimeter size left axillary mass. Initially, patient underwent ultrasound, which shows no evidence of any disease on the right side, but on the left side, there were 2 tumors in the left breast. First was around 12 mm in largest diameter, and the second was around 11 mm in the largest diameter. USG of the left axilla shows multiple abnormal lymph node in axillary level 1, 2, and 3. Also revealed a lymph node in supraclavicular region as well. So all the lymph nodes were clipped or coiled, and for the further treatment monitoring. And biopsy was taken from both the tumor. So first tumor turned out to be IDC grade 3. It was ER negative as well as HER2 negative, which was confirmed by the silver enhanced in situ hybridization, and Ki-67 index was 90%. And the second tumor also turned out to be IDC grade 3. But it was hormone receptor negative, but it was HER2 positive, which was also confirmed by SIHS, and the Ki-67 was around 70%. And same FNSC was done from all the lymph nodes, including the supraclavian lymph node, which was involved by the malignancy. So we have a patient of a multifocal breast tumor. Both foci has a high risk pathology. One has the TNBC, one has the HER2 positivity. And this is the baseline PET, which shows that there was no distant mets, but multifocal breast tumor with heavy burdened left axillary lymph nodes and left supraclavian lymph node as well. So it was stage 3C. It was staged as a group stage 3C. And after the multidisciplinary team conference, it was planned for the new adjuvant systemic therapy. She was treated with 4 cycles of weekly paclitaxel along with the subcutaneous trastuzumab and pertuzumab, followed by 4 cycles of epirubicin and cyclophosphamide chemotherapy. And for the response assessment, 2 times breast MRI was done. First was done after 2 cycles of the chemotherapy to assess whether there is a response, whether the tumor is chemo responding or not. And 2D echo was done every 3 monthly. And after 8 cycles of chemotherapy, there was excellent clinical response. There was no palpable breast tumors, and there was regression in the axillary lymph node as well. So the MRI was done before the surgery, and it showed that there is complete response in the breast as well as there is a regression of all the lymph node. And ultrasound confirmed that there was no residual lymph node, and FNS even was tried from the suspicious tissue, which showed no evidence of tumor as well. So this patient was planned for the breast conservative surgery along with sentinel lymph node and as well as targeted axillary lymph node dissection. And so the BCS was done with these coiled mark tumors, and targeted axillary dissection done with removal of only 1 lymph node, which appeared to be seemed positive by the sentinel on the as per sentinel lymph node biopsy. And after, as per the histopath report, it was turned out to be a pathological complete response. Residual cancer burden was 0 with no DCIS. And lymph node also shows no residual metastatic carcinoma, which shows excellent treatment response. And which the patient which was initially staged at a stage 3C now was staged as a pathological complete response. And further treatment was planned in the form of adjuvant radiation therapy and adjuvant trastuzumab for 1 year and zoledronic acid every 3 monthly. So during the radiation planning, high resolution CT scan with IV contrast and baseline PET-CT was used to delineate if there is any residual lymph node that might have been missed in pre-op assessment or during the surgery. And if they were boosted with radiation therapy as well. The total radiation therapy was done 40 grain 15 fraction, and the suspicious lymph node were further boosted by 10 grain 5 fraction. So this is the adjuvant treatment plan that we just discussed. And after that completion of the treatment, patient has been asked to come in the oncology OPD every 3 months for the next 1 year. And after the 18 months, patient was advised mammosonography along with sonography of abdomen and pelvis and chest X-ray every 2 years. And so these are the points to be discussed. So our patient has a very aggressive biology. One was a TNBC with a higher Ki67 index of 90% with coexisting HER2 positivity as well. And we have treated the patient with HER2-directed therapy. So is there any role of systemic therapy to target TNBC component like adjuvant capecitabine or PARP inhibitor in BRCA positive patients?
I would have treated her with dual anti-HER2. I don't know what's responsible for that N3 disease, and we won't know because those nodes didn't remain. And first of all, I think they really pushed the boundary with taking de-escalation too far. I don't think in an N3 disease one would, I don't know, in most centers, omit a formal A3 lymph node dissection. And I'm a little scared that they've called this PAT-CR by just doing a targeted axe dissection. So that is my concern. And I would, if you've treated her within as a high risk and you've labeled her as a, I think, T2N3 disease, you would need to continue dual anti-HER2 in the adjuvant setting. I would do that. I don't know about my other colleagues.
So I also completely agree here, ma'am. Even if the surgery was de-escalated a little bit because of probably the thought process that this is this is a systemic problem, not as much as, see, when do you de-escalate? You de-escalate when you are completely relaxed and you say that whatever therapy has happened, there's nothing coming back. Or you de-escalate when there is too much that will happen if you gave the full definitive treatment to a patient. And it happens to us with oligometastatic patients all the time, where the radiation oncologist will say, or where the surgeon will say, these are what you saw. There's much more beyond. What all will you take out? Do whatever you did, and then if you see a disease movement, then we will take care of that. So even if they did it in that spirit, the de-escalation, honestly, the HER2 directed therapy is the systemic therapy that would have been warranted, and HER2 is something that I would have said.
And I think another thing our students need to remember is that even a PAT-CR in a HER2 positive patient, unlike triple negative, doesn't mean the disease is not coming back. 10 to 15% of PAT-CRs in HER2 do relapse. All right. And that's always been a problem for us because we achieve very high PAT-CR rates with anti-HER2, more so than TNBC. But we see more relapses in spite of PAT-CR. All right.
And the long-term survivals are now with dual HER2 inhibition. Those are the numbers.
Correct. So you can't get away with just single agent trastuzumab in this patient. I think that's why this case was brought to this meeting, because there would have been a lot of discussion regarding the surgery and the maintenance therapy and the heterogeneity of having a HER2 negative and a HER2 positive tumor in the same breast. So, this basically highlights tumor heterogeneity.
Yes, ma'am. Thank you. Ma'am, one more thing.
Great cases.
Yeah. Tell me, Piyush.
Yes, ma'am. Ma'am, since the patient is elderly female, and she was at baseline, her cardiac functions were normal. So, which might not be applicable in each and every patient. And we are giving in dual HER2 blockade as well as adriamycin-based chemotherapy. So, how can we manage such patient to prevent long-term cardiotoxicity?
So I think when you think of the two agents, the anti-HER2 is a more reversible, more controllable toxicity, whereas the anthracycline is a little more dangerous. It can come up after many, many years, and it is non-reversible. So the good thing is she's received only 4 cycles. So it is a cumulative toxicity, as we know, and that's not going to happen or should not happen with this dose. But I can't understand again why TCHP or THP for 6 cycles was not given to this patient. That would have been a gentler regimen considering her age, and an effective regimen as well.
Okay, yes. Thank you very much.
Chakor, do you want to take over the panel discussion, please?
Yes, ma'am. I will start sharing the slide.
So Dr. Chakor is a medical oncologist who is a Tata graduate, came to Pune more than almost 10 years ago. He's leading the oncology at Sassoon General Hospital, where he runs a wonderful daycare and treats the patients there. So he's a professor there. And he's also with Ruby Hall, and he's a senior medical oncologist and consultant there. So please go ahead.
Ma'am, I'm just trying to share the slides for...
No problem.
It's not there, right? You can now share. एक मिनट screen desktop is not open.
Hello? Yes?
Ma'am, actually, it's the desktop is not being shared. I will email the file quickly to Mr. Christian, and I will
Yes.
start the discussion in a moment. Yes.
Yes, doctor. You could probably just share it with me quickly, and I will ask the organizers to share.
Can you just wait a minute? Yeah. So
If my screen is visible,
Daud, I believe there are some changes from the original deck, so maybe
I've
Dr.
made a few
Sharma can
changes.
share it.
So
Yes, fine.
Okay, so while Mr. Christian gets the slides and he uploads, so first of all, I'll thank ma'am as well as AstraZeneca and the organizing team to give me this opportunity to moderate this session. So the panelists today are Dr. Jayant Gawande, a medical oncologist in Pune and Pimpri Chinchwad. He's been in the field for last 13 to 15 years. Dr. Mangesh Mekha, who's again a medical oncologist from Pune, working with MOC, and he's also in the field for last more than 10 years. Dr. Abhinav Zawar and Dr. Anup Toshniwal, both of them from Chhatrapati Sambhajinagar. So both of them are my friends from Tata Memorial Hospital. They've been working at Chhatrapati Sambhajinagar since 7 and 5 years respectively. And we have Dr. Aishwarya Gole, who's a medical oncologist working here in Pune for the last 1 year. So she's done her graduation at Dinanath Mangeshkar Hospital. She's completed her DNB medical oncology over there. So yeah, this is not the presentation. So maybe you can go to your. This is not the one which I wanted actually. So yeah, so this was the rough one which has been shared. Just a minute. Yeah. It's okay. So we'll go ahead with this one only. So the picture of the first man in the first picture. So can anyone just guess who is or who he is and why is he so relevant to us? And the second man also. The picture of the second man. I believe this person is at least known to a few of us.
Yes, of course.
Yeah. So he is the first picture is of Dr. Stanley Cohen. He's the one who identified what is epidermal growth factor, and he received a Nobel Prize for that. And the person on the screen just now, he is Dr. Dennis Slamon, the one who is credited for pioneer work in the field of HER2 in breast cancer. And so ma'am definitely knows him, and she mentioned that. So Dennis Slamon was the one who pushed Genentech to do the trials of trastuzumab, which was non-existent at that time. And in the year 1992, they started with a phase 1 trial, went on to phase 2, and finally the phase 3 trial, which was published in 2001. So we can move on to the next slides. The next one. So this is just a preclinical evolution of HER2 targeted or how HER2 was identified. 1962 was the discovery of EGF. 1982-85 was the discovery of HER2. The development of monoclonal antibody happened in 1990s, 1992. Next slide. So this is a pictorial showing how the HER2 signaling pathway works, and but this has been mentioned by Dr. Sevanti. So we'll go to the next slide, and we will. Actually, this is all the slides are here and there. Anoop has joined. Okay, so the next slide, please. So again, evolution of HER2 targeted therapies over here. Next slide. So I request Gawande sir to please tell us how the HER2 targeted therapies have evolved over the last 25 years.
Yeah. Thank you, Chapor. I don't remember the dates exactly, but
Yeah.
let me try. So HER2 targeted, I guess, came first in the metastatic setting. That was in the late 90s, I guess. And then we had the 5 major trials in the adjuvant setting where it greatly changed how we treated our early breast cancer patients who were HER2 positive and with a very impressive hazard ratio of 0.5. And since then, we have been practicing adjuvant trastuzumab for all our HER2 positive early breast cancer patients. Then came, I guess, pertuzumab, which again.
You can go to the next slide,
Yeah.
Christian. Yeah, yes, sir.
Yeah, in the metastatic setting, and then it moved to the adjuvant, and then in the adjuvant, yeah, and then in the neoadjuvant setting. And recently we have these ADC with TDXD, which again showed very promising results earlier in the metastatic setting, then moving on now to the adjuvant as well as the neoadjuvant setting. We have had other TKI inhibitors which also have shown role mostly in the the metastatic setting.
Okay, so yeah, we can move to the maybe 10 slides ahead now. So I just put in the slides of the Cleopatra trial, the Emilia trial, because I wanted to focus more on the metastatic setting. Yeah. Who's controlling the presentation?
Team, if you could move the slides ahead as being requested.
So sir has mentioned pertuzumab, Cleopatra. Yes, the next one, Emilia. Next one. So trastuzumab emtansine, and then the next one. Yeah, again, the next one, please. Next one. And the next. So coming to trastuzumab deruxtecan in metastatic setting, Dr. Sevanti Limay has already discussed these studies, but I'll just as a revision for all the students, can I request Dr. Abhinav Zawar to please tell us a bit about the DB03 trial, the Destiny Breast 03.
Good evening, sir. Good evening, everyone. I think the DB03 was a landmark trial because it was the trial wherein the TDXD versus TDM1 was compared in second-line HER2 metastatic diseases. And I think the results were pretty impressive. There was OS advantage, PFS improvement, massive PFS improvement, and the response rate were almost like 80% response rate. So and previously heavily treated patients were taken there. So I think that was the game changer.
Okay, Abhinav. And can you tell us about DB09 as well, please?
So, sir, in DB09, it's TDXD, and now this is potentially like a paradigm shift we are getting, wherein we are going to give TDXD plus pertuzumab versus THP in the frontline setting. And I think the PFS also is quite high. The PFS of, I think it is something like 40 months versus 25 months, and with a hazard ratio of 0.5, probably. I don't remember the exact figure, but yes, 0.5 hazard ratio and a PFS of 40 months and in frontline setting. So I think with future, I think probably we'll end up with using TDXD plus pertuzumab rather than THP as a frontline setting. So, and probably the like for ADCs will come into for frontline setting.
Okay, Abhinav, thanks a lot. So I'll just leave aside this presentation. Anyways, we are not able to go ahead with it. I'll straight focus on the questions that are in mind and that we need to discuss. So the first thing is, what's your first line treatment today in metastatic breast cancer patient who's HER2 positive? You can stop sharing the presentation. We can just have the videos on and leave the presentation aside. So Anup, if you are here, you can please tell us your thoughts. What is your first line choice, or what is the first line treatment that you do for your patients who are HER2 positive?
Chakor, good evening, everyone else. What I do right now is for low volume of disease and otherwise no brain mets, I prefer first line as THP only right now, taxane plus HP. Brain mets is there, or the disease burden is high, then first line I prefer giving in HER2. Other than that, in real world scenarios, other things also come in play, like whether patient is financially affording or not. Then sometimes I only give maybe platinum with the taxane, platinum plus trastuzumab, or taxane with this HER2-directed therapy trastuzumab.
Okay, so will it be only so you will choose between THP and trastuzumab deruxtecan? That's what you say?
Yeah. And if affording, then per 2 plus in HER2 also.
HER2 plus and HER2. So basically DB09 is what you are saying.
Yeah.
First line. So DB09 first line for a patient who is metastatic HER2 positive breast cancer, that is your choice. Suppose if this HER2 positive breast cancer patient is also endocrine receptor positive.
So in that case, if suppose the disease burden is not that great, we can use CDK4/6 inhibitor plus in AI with the this TH.
Yeah. So trastuzumab, pertuzumab plus a CDK4/6 inhibitor
CDK4/6
and aromatase inhibitor. So that will be your choice. And why is it so? Why would you not
because
for
we had
DB09?
Yeah, because we have that trial where the toxicity is less, and otherwise we know from our past experience that it will be a chemo-free regimen, and it will be more comfortable for the patient, and the benefit is more or less same. So that will be in the terms of toxicity, it will be preferential.
Okay. So first line HER2 positive, hormone receptor negative, you're saying THP or TDXD plus pertuzumab.
Yeah.
Right?
Yeah, and for HR positive and
And someone who's affording, you will go for TDXD per 2, or you will still offer THP?
Rather than affordability, what I think is that brain mets, high volume of burden of disease, I would prefer HER2 plus per 2. Low volume, not very critical like brain mets, then I would prefer 6 THP. Obviously, we can argue on both sides, but this is I follow right now.
Okay. So any other thoughts, Abhinav?
Sir,
with Anup on all the points, or you have some difference of opinion?
No, more or less the same. If probably in metastatic setting, in any respective of whatever it is, I think now the data is DB09 data is there. It work wherein it hormone receptor positive, be it any kind of PIK3CA mutated, it works like it's working like a it's like working like a miracle. So probably I'll go with DB09. In
Yeah.
a high volume disease, cost is not a issue, wherein most of the time we have cost is a issue. So probably if cost is set aside, probably DB09 will oversee everything and anything.
Exactly. And that's because of the statistics, because Cleopatra, where THP was the first line, the median PFS was 18.7 months as compared to 40.7 months in DB09. So that probably makes DB09 regimen the first line regimen for someone who can really do it. So, and as Anup rightly said, if it is a hormone receptor positive patient, then the option of patina is really is a very good alternative and a very good option over there as well. Ma'am, will you like to opine on this? Like, what will be your first choice?
So, I don't know what the subgroup analysis was for the DB09 between the hormone receptor positive and negative. But yes, I would base my decisions on ER positivity, where I think the patina is an excellent approach. The PFS is 44 months compared to DB09, which is 40 months.
Yeah.
All right.
Yes.
My only concern is if I use TDXT upfront, what the hell is going to happen later? And, like a patina-like approach for ER positive, I use TDXT second line, I get 28 months.
Yes.
So I'm getting a lot if I use sequential treatment in ER positive. The issue is the ER negative, the PIK3 mutated, the high tumor burden, the brain metastasis. I get 40 months, but then I know that once the patient progresses, I'm not going to get more than 4 or 6 months with any treatment. So that is a concern, and I hope there are some newer drugs or optimal sequencing strategies coming our way.
Okay, thank you, ma'am. Yeah. So that's about HER2 positive, her hormone negative, and HER2 positive, hormone positive. Now, coming to the hormone receptor positive patients who are till recently, till a couple of years ago, we used to say hormone receptor positive, HER2 plus or HER2 plus, HER2 fish negative. We did not have any option, or we did not have we used to not think of targeting HER2. But with the DB04, with the DB06, these all patients are now open to the benefits of TDXT. So, what is your current first line treatment, preferred treatment in a patient with hormone receptor positive? Gawande sir?
Yeah. So for a hormone receptor positive patient, we need to look at the biology of the disease, if possible, by assessing all the biomarkers. Then we have to look at the disease burden, the volume of disease, whether or not the patient is in a visceral crisis or not.
Yes,
and
sir.
then the patient parameters and choices. And depending on that, we take a call. But most of the times, it is a hormonal therapy with a CDK4/6 inhibitor.
Okay. And so let us dig a bit into this topic. So if it is a patient who's in visceral crisis, then what will you do?
So here again, it is not a one treatment fits all situation. You have both the options of doing you have the right choice study and two other studies which show that even in patients who have a heavy tumor burden and an impending or an actual visceral crisis, a CDK4/6 inhibitor may still work there, but then you have the option of chemotherapy in the first line with a visceral crisis patient.
Yes, sir. I agree with you. So, and someone who's not in crisis, you will, as you mentioned, you will start with CDK4/6 plus an aromatase inhibitor or an endocrine therapy, OFS plus tamoxifen or OFS plus.
Premenopausal, postmenopausal. Yes.
Yes. So that's that. Now, a patient who's 70-year-old started on.
Can I make one comment?
Yes, ma'am.
So it's quite amazing that, TDXT has been used instead of AC in neoadjuvant, in the neoadjuvant approach.
Yes, ma'am.
Could you use I'm just playing the devil's advocate. You have this high tumor burden, you have maybe brain mets, you have ER negative, HER2 enriched disease. Could you use TDXT for 6 cycles with pertuzumab, get a control, and then maintain them on Trast and Pert? Because we know that long-term Trast and Pert is very well tolerated with a good quality of life. And what you want is a quick response and a deep response. So that may be one strategy. You know, there are so many ways of thinking of this anti-HER2 and the disease that, and then the patient is not exposed to ILD or anything like that. And you could possibly re-challenge after
Yes.
the 2-3 years that you get of PFS. You could possibly re-challenge with TDXT at some point.
Yes, ma'am.
So
That looks like the best midway where you can.
I'm just thinking, I mean,
Yeah, you
what do
could
we
do a
do?
TDXD followed by patina or
And
whatever. Yeah.
absolutely,
Mm.
just to get a hold, like it is chemotherapy. It is
Yeah, you cannot give it
so
for long. Yeah.
no, and it's a sophisticated way of delivering chemotherapy. That's what
Yes,
it is.
that's what it is.
So
Yes.
yeah. So
But ma'am, doing like the strategy sounds really good, but without the data, will you do it?
will
Like,
there be? I'm asking you, Chakor. Will there be data?
no, there will never be a data of this kind. But
Yeah. So we've got to think for our patients.
Yes.
We've got to think about India. We've got to think of affordability. We've got to think of quality of life of Indian patients. So I think, if all of us can reach a consensus, this can be discussed in meetings on how best to give TDXT in the Indian setting. It could be a very valuable lesson for all of us.
yes, I agree. So now coming to the topic of HER2 low and HER2 ultra low. So can anyone volunteer to tell us how do you define what is HER2 low and what is HER2 ultra low? We do not have a pathologist on the panel today, and the slides are not here. So I'll request anyone who's good at defining that to please volunteer and tell us.
So HER2 positive is IHC3 plus, which is well defined, and earlier anything which was or IHC2 plus and FISH positive, anything less than that was earlier classified as HER2 negative, but now we have the low and ultra low.
Yes.
So HER2 1 plus and HER2 2 plus ish negative is HER2 low, and HER2 zero with faint incomplete membrane staining in less than 10% of the cells is now HER2 ultra low. And the absolute no staining is the HER2 null status.
So that's the true triple negative patients or true HER2 negative patient.
Yes.
Okay. And to give, so Dr. Aishwarya, can you give us the percentage of patients as per the current data who are truly HER2 negative, who are HER2 low, and who are HER2 ultra low? So we know that around 15 to 20% or 20% is what is HER2 positive patients. The remaining 80%. So what is the current volume of or number of patients who will benefit with this or who are likely to benefit with this strategy or definition of low and ultra low?
Yes, sir. So, about you said 15 to 20% are HER2 positive group, and in that HER2 low are about 50 to 60%, and about 10 to 20% are HER2 ultra.
Okay, and the remaining 10 to 20 to 15% are triple negative. So we have around 60% of breast cancer patients who are like who are likely to benefit with this definition of low or ultra low, and then the TDXT may be useful over there, as has been shown by 2 trials, DB04 and DB06. So when in your practice will you consider using TDXT for a patient who is hormone receptor positive? Abhinav?
Sir, probably in a very like one is heavily treated, one is the if she is PIK3CA mutated, probably then there is a prior adjuvant pertuzumab trastuzumab has been used, a short disease-free interval, and a high visceral burden of the disease, and you want a deep responses, probably I would consider DB09.
Not hear you, Abhinav. Maybe Anup, you can.
I will repeat it. Am I audible now?
Yes, Dr. Abhinav, you are audible.
So I think Chakor sir has a network issue, or I have network issue. I am not.
Maybe I had a network issue. I don't know. Yeah.
Okay. So what? So your question was, where should in a hormone receptor positive, where should I consider adding DB09? So probably you are there, sir.
Yeah, I'm here.
Yeah. So probably a heavy visceral disease, then a short disease-free interval between the use of trastuzumab, pertuzumab initially. Then you have a PIK3CA mutation.
Abhinav, my question was to be more specific, it is about patients who are hormone receptor positive and HER2 low.
Okay, hormone receptor positive and HER2 low.
Yes. So in that setting, will you use TDXD? If yes, in which line? In which setting?
Yes. So I would use TDXD, but not upfront. Maybe in second line I'll use it. I'll use it in the second line. So
Okay.
first line, HER2 low, hormone positive, I'll go with the hormone therapy.
Okay. And so, yeah, that is true. So, and which patient will you select? Will you use some biomarkers to select, as you were referring to PIK3?
Yes. So if initially I'll start with the therapy, but if there is a PIK3CA mutation and a short, you have a progression on CDK4/6 inhibitor immediately, for within 6 to 8 months, you have a progression, then maybe I'll push over to TDXD, because then probably I feel it is more of a endocrine resistant biology, and I'll go for TDXD.
Okay. Ma'am, so Nag ma'am, Dr. Nag, can you please tell us a little more about how will you choose the next line after failure of CDK4/6 and aromatase inhibitor?
So basically, in patients who've had a nice long progression-free survival, as mentioned earlier, with CDK4/6 and hormone therapy, I'm very inclined to try out a second hormonal therapy, and sometimes even a third. And of course, it depends on the disease burden, the performance status, the age of the patient. And the case that Dr. Bhakti presented was about 4 or 5 lines down. She had finished Paclitaxel, she had finished capecitabine, CDK4/6, everolimus, exmestane. So she was 4 lines down, and there was HER2 2+ Fish negative. And I thought with her liver burden, that was the right patient to consider TDXD, because they are highly resistant patients. So yeah, so all these characteristics make me want to, also as mentioned by a person who progress. So patients who progress on CDK4/6 inhibitors fast are usually PIK3 mutated, and some of them are BRCA mutated as well. So you do have treatments for those, but you and I know how badly patients tolerate alpelisib. So
Yeah.
maybe in that setting, TDXD would be a good choice.
Okay, ma'am. And what about ESR1 mutation? So
So ESR1 mutation patients do respond to CDK4/6. It's just the partner that is not right, perhaps. And they do get a decent PFS. I've had patients, and ESR is something that is acquired along the way. It's not like a PIK3CA, which is present right from the beginning. So I tend to check for ESR1 6 months out.
Okay.
And then if the patient progresses, say a year later, that's when I check again. And once PIK3 is negative, they don't acquire PIK3. So ESR is something that is dynamic, that keeps changing. And so is the HER2 status. So that can come from low to ultra low. And that's something you need to keep checking from negative to low. So these two markers have to be checked.
So should we be doing PIK3 at baseline and then ESR1, as you mentioned, at 6 months and 1 year and later?
So because I don't have inavolisib available for the first line setting where I can use it with a CDK4/6 and hormones, I normally do all these tests after progression on first line therapy.
Okay.
Then I check for all the markers. Sometimes if it's an aggressive relapse, then I do a CGP as well to look for agnostic markers, to look for anything that might be useful in that patient.
Yeah, thank you, ma'am. Thank you for that insight. So lastly, will you use the TDXT in a similar patient who's got an ultra low expression of HER2? Anup?
I would use it beyond second line, and I would like more be preferring to chemo and post progression on at least 2 hormone and 1 chemo line. Then only I'll use, because it is low, ultra low rather than low. So I think the efficiency might not be that good as compared to if you get using low.
Okay. Is it in spite of DB06, like the number of patients with ultra low were less, 77, 76 in both the arms, chemotherapy versus DB06 versus TDXT, but at least in that trial, in the DB06, that subgroup of ultra low, the TDXT showed better responses as compared to chemotherapy.
No, but that setting is completely different. No, you are talking about ER negative and HER2 positive, HER2 ultra low. Here we are going beyond first line, second line hormone. You will get lot of mutations which are there, and then rather than targeting some particular receptor on the surface with the low expression, I would rather bomb it with the non-specific cytotoxic chemotherapy. And then if I don't have any option, then I will use it. That is what I think.
Okay.
Obviously, we will not get very good data about I think second line and beyond. But like I had done, suppose NGS for 2 to 3 patients in third or second or third line beyond in HR. What I find, there are multiple mutations which are there, and targeting only one mutation or only one receptor, I am not very comfortable. I would rather use some chemo, and then if required, and also the other things like finances, tolerance, and the sites of meds, burden of disease, all that matter. But I would be inclined more towards chemotherapy.
Okay.
But this is chemotherapy.
Yeah, but madam, it's more of a targeted
No,
chemotherapy.
I don't agree with you. I think you're using irinotecan, which is perhaps for the most refractory resistant patients that we do. Yeah, in a very sophisticated form. That's all it is.
Eribulin plus Bay or K plus Bay or like irinotecan, that kind of.
See, I think what you're saying makes a little sense, because once you use TDXT to get responses from other drugs, I've found it miserable. I've not had good PFSs at all. Whether it's triple negative HER2 low or whether it is ER positive HER2 low, nothing seems to work because it's so potent. So I think you have a thing there. Give the chemo first and reserve the TDXT for later.
So, just wanted to ask one question. There are some subset of patients, either TNPC or HER2 ultra low. They don't respond to any kind of treatment. Like they keep on progressing every 3 4 months on 3 to 4 lines. That patient is very rare in 100 MBCs, might be 2 to 3. has anyone used TKI in that setting, like lenvatinib, cabozantinib? Anyone has used? Madam, what are your thoughts? Because one patient, even I've referred to you. She was young CA breast triple negative upfront metastatic with brain mets. She progressed on 3 to 4 lines of treatment. And then it was not responding to AC, taxane,
Right.
platinum, gemcitabine, eribulin, irinotecan. So I finally thought of using len or cabo.
And did that work?
She succumbed before starting it, actually.
Correct. No, so there was some very old data of sunitinib in triple negative breast cancers, one of the SOLTI trials, but that was a negative trial. So I haven't really used TKIs. And I think eribulin with Bev is a good combination for the more resistant patients. And I have used that with some success even for brain mets. But really, this you're talking of this Claudin low, really bad stem cell like patient who does not respond to anything, and it's nobody's fault. I mean, that's a disease, really. Maybe you'll get some more treatment soon.
Yes.
Maybe datopotamab will work for these patients. It's just been approved for triple negative.
Yes, yes.
So,
And I
yeah,
think 2 days back.
yeah.
Okay. So coming to the last part, biomarker testing. Dr. Sevanti Lima is here. Ma'am, I'd like to know from you, or rather all of us, you are you are a leader in liquid biopsies. You have done a lot of work on that. So can you tell us where exactly, which patient you will do the liquid biopsy? Where will you go for a solid, for a tissue biopsy again? At relapse or like on progression? What is your algorithm of working?
So, unless I'm looking for an ESR1 or a PIK3CA, my pitch is mostly to look at a tissue. But many times patients have had a biopsy and there isn't enough tissue, or the biopsy site is not reachable, just bony metastasis and bony progression, brain progression. In those situations, we have utilized liquid biopsies. But especially for brain progression, I've seen it fall short severely. I'm treating a HER2 positive, AKT amplification positive patient now. For last 3 years, she's on capivasertib and HER2 directed treatment. And this is a patient who would not have had anything positive in a liquid biopsy, but for the fact that we had done a brain biopsy with which we sequenced and we figured out it was HER2 and AKT amplification both together. This patient has also been treated at Proton Center and then blown past the radiation, and then we had to put her on dual targeting. So I feel that there are nuances to each, but breast cancer is a cancer where we have the luxury of many drugs. So even if we don't test early on, these patients actually behave really nicely with the kind of drugs we have. And now we have Enhertu, which is also a great treatment transforming, outcome transforming medicine. But if the patient is not behaving the way we expect the patient to behave, we must sequence, and we must sequence quickly because the drugs are there. Many a times we may end up missing.
Okay.
So that's my 2 cents. But Enhertu is a very powerful drug. We actually have a current patient that tested ultra low, completely negative, not even ultra low, from 2 different labs, and is a patient who has responded on Enhertu for 8 months. So, it's a strong drug. And while awaiting the TROP2 inhibitors launching in India, I think this is a great blessing to have Enhertu in the country.
So yeah, definitely, I agree with you that NR2, the trastuzumab deruxtecan, that is a wonderful drug. All the trials, let it be like in the metastatic setting, let it be from DB03 to DB09, and then even the low DB04 and 6, all are good trials. All have given good data and a lot of hope to our patients. So yeah, thank you AstraZeneca for getting that drug over here and all the patient assistance.
And I think across a lot of tumor types as well.
Yes.
So,
Yes.
and used it in gastric, I've used it in colon with some success. So it's, and even lung, of course. But the question is the testing. I think maybe better sensitization of our pathologists to look for any faint staining if they may pick it up, because it does matter in the end.
Yes, ma'am. So with that, I thank all the panelists for their contribution. I apologize sincerely for the glitch in the presentation, and I thank again Dr. Shona Nag.
Great moderation, Dr. Chakur.
Great, Chakur. So I think we've had a great evening. Thank you so much. And we finished well within time. So thank you to all the experts who came on board. And Chakur, thank you very much, Jayant, all of you. And thank you, Sevanti, for sparing 2 hours on a Saturday evening.
Oh, you've done it so well, ma'am.
Not at all. It was
Pleasure.
nice discussion.
Cases,
Thank you.
Moderation, cases were lovely. So congratulations.
Thank you so much. And thank you, AZ, for supporting us as always. Thank you.
Bye-bye.
Thank you, everyone.
Thank you.
Have a nice
ma'am.
weekend.
Tech team, please close the meeting.
Yeah, support team, please close the meeting. Thank you. Thank you, Daud. Thank you so much for your time. Thanks,
Thanks,
Dr.
sir.
Krishnan. Yeah, bye. Thank you. Thank you.